Okay, let's talk about allergic rhinitis. Allergic rhinitis, which is also known as hay fever, is an IgE-mediated inflammatory condition of the nasal mucosa, triggered by exposure to airborne allergens such as pollen, dust, mites, mold spores, or pet dander. It may be seasonal, occurring during specific times of the year when allergen levels are high, or perennial, with symptoms persisting year-round due to constant exposure to indoor allergens. The pathophysiology involves a type 1 hypersensitivity reaction, in which allergen exposure stimulates B cells to produce allergen-specific IgE antibodies. These bind to mast cells, causing degranulation and the release of histamines, leukotrienes, and prostaglandins, leading to nasal mucosa inflammation, increased vascular permeability, and mucus hypersecretion. Patients commonly present with sneezing, clear rhinorrhea, nasal congestion, postnasal drip, and itching of the nose, throat, or eyes. Fatigue and sleep disturbances are frequent due to symptom burden. Physical examination often reveals pale, boggy turbinates, clear nasal discharge, allergic shiners, which are these infraorbital darkening from venous congestion, a transverse nasal crease from the allergic salute, and possible Denny-Morgan lines beneath the lower eyelids. The diagnosis is primarily clinical, but can be supported by elevated total IgE or allergen-specific IgE testing via RAST or skin prick testing in persistent or severe cases. First-line management includes intranasal corticosteroids, which are the most effective treatment for nasal symptoms, often combined with second-generation antihistamines for itch and sneezing. Intranasal antihistamines can be used for rapid relief, and saline nasal irrigation may help with mucosal clearance. Leukotriene receptor antagonists may be considered, especially in patients with concomitant asthma. In cases refractory to medical therapy, allergen immunotherapy, either subcutaneous or sublingual, can reduce symptom severity and modify disease progression. Allergen avoidance measures, such as using HEPA filters, encasing bedding to reduce dust mite exposure, and limiting contact with pets in the home are important adjunctive strategies. Complications of allergic rhinitis include sleep disturbance, chronic sinusitis, otitis media with effusion, and worsening asthma. On board exams, key buzzwords include the allergic salute, allergic shiners, pale boggy turbinates, and IgE-mediated hypersensitivity. Patients should be counseled that intranasal steroids are most effective when used daily, not as needed, and the sedating first-generation antihistamines should generally be avoided in older adults due to anticholinergic side effects.